This is a vomiting semiology presented by Dassi Bopda with a reference, a practical guide to history taking and clinical examination by Anwar Qais Saadoon. So we're going to visualize now vomiting. So what is the definition of vomiting? Vomiting is forceful expulsion of gastric content through the mouth. That's the simple definition of vomiting. Vomiting is the forceful expulsion of the gastric content through the mouth. It can be divided into three phases. You have nausea, you have retching, and you have emesis. So these are the three main phases of vomiting: nausea, retching, emesis. It is not necessary that these phases occur together. Sometimes you may not have nausea, but you must have the retching. When you don't have retching, then it's not vomiting. Are you getting? Retching is that sensation, that forceful event. Are you getting? The forceful event in itself is the retching, and emesis is when it comes out. You may not have emesis in vomiting. Sometimes it may just come into your mouth without coming outside your mouth. Are you getting? But there must be retching. Okay. So nausea can be defined as unpleasant, uncommon sensation of needing to vomit. So that is nausea. But there are times when the disease is not preceded by nausea, it means that the vomiting may be coming from the central nervous system. If there is just retching without disease being preceded by a period of nausea, so that's much more going to be due to a central nervous system event. So nausea is unpleasant, uncomfortable sensation that you want to vomit. So retching is defined as a coordinated contraction of the abdominal and intercostal muscle and the diaphragm. So abdominal, intercostal, and diaphragm, so associated with a closed glottis onto the larynx, so that there is no expulsion, so that associated with the closed glottis. So you have the contraction on a closed glottis of the esophagus. Are you getting? So that there is actually the build up of pressure. Are you getting? So that there is no expulsion of the stomach content yet. There is just a build up of pressure. So the glottis is closing the esophagus, so that there is not yet the expulsion, but there is just a build up of pressure. So vomiting should be differentiated from regurgitation. Are you getting? Which is small, effortless. There is no retching, effortless bridging up of 1 to or 2 mouthful of food sample. So when you are eating excessively, you don't really want to vomit. You are retching. That's belching out. So when you are regurgitating, so you are regurgitating and not vomiting. Acute vomiting is commonly caused by infection. Viral infection, e.g. the norovirus or rotavirus. You have metabolic condition. You have toxic ingestion like food poisoning. You have surgical emergency, appendicitis, ovarian torsion. The next one now, this is the history taking vomiting. History taking vomiting, we have the age, the sex, and address and identity. So we have the chief complaint is vomiting, history of presenting complaint, we have the duration of the vomiting, the timing of the vomiting, we have the frequency of the cause of vomiting. You have to characterize the vomiting, you have to characterize the vomitus. To characterize the vomiting, you have to say if it is spontaneous, if it's associated with any food intake or any drug, anything that was intake, if it was projectile or not, and then you characterize the vomitus. So we have duration, acute or surgical causes vessel. So we have acute, it can be infectious or surgical causes when you have acute vomiting, or it can be chronic vomiting. So the timing, we have early morning, daytime, nighttime. You have frequency or cause of vomiting. You have characteristic of the and the content of the vomiting. If the characteristic of vomiting is projectile, you have it is spontaneous, effortless. You have bilous, non-bilous, feculent, undigested food. So this is bloody coffee ground appearance. So all that is a character, the content of the vomitus. So we have relationship to meals. Vomiting of gastroesophageal reflux or gastric ulcer is relieved by eating meals. So we have associated symptoms. You have fever, diarrhea, nausea, abdominal pain, retching. Jaundice suggests hepatitis. If you have jaundice with vomiting, it suggests hepatitis. Pain or swallowing, and mostly hepatitis that affect both the gastrointestinal tract and the liver is a hepatitis A virus. So we have past history, we have birth history, maternal infection, we have maternal smoking during pregnancy, antenatal ultrasound scan finding, we have maternal polyhydramnios, pre and prematurity resuscitation, past medical and surgical history, diabetes, peptic ulcer, central nervous system, contraception, and all that. So medication issue, you should know the antibiotics that causes vomiting, digoxin causes vomiting, theophylline, chemotherapy, anticholinergic, morphines, all that causes vomiting. Feeding, so the type of feeding a child has, the feed volume, the frequency of feeding, overfeeding, proper formula preparation, effects, so all this can result to vomiting. Family issue is a family issue of vomiting, family issue of surgeries, in case of malrotation, Hirschsprung disease, in case of hiatal hernia, family issue of atopy, food allergies, and migraine headache. So those are the family issues you have to ask here. Now the key point, acute vomiting associated with fever that persists for more than 24 hours should raise suspicion of meningitis. Acute vomiting that with fever that persists for more than 24 hours should raise suspicion of meningitis. Meningitis can occur with vomiting, and this vomiting is a projectile vomiting, especially if there is no associated with diarrhea. So if there is no diarrhea, there is just vomiting and there's fever, you should think of meningitis. Persistent vomiting in neonates or young infants who have no signs of infection may suggest congenital intestinal disease. So a neonate or young infant with no signs of infection, think of a congenital gastrointestinal abnormality. So example, we have pyloric stenosis, we have duodenal atresia, we have intestinal atresia with this vomiting. We have central nervous system. Another thing you have to think is central nervous system abnormality in these patients, and you have to think inborn error of metabolism. Bilous vomiting is always pathological, so suggests intestinal. If you have bilous vomiting is always pathological and suggests intestinal obstruction. A sudden onset bilous vomiting is in a previously healthy should consider. So if you have sudden onset bilous vomiting in a previously healthy neonate, should lead to consideration of malrotation with secondary midgut volvulus. So we have malrotation and then we have a volvulus. So this which needs urgent surgical assessment. Bilous vomiting with blood in stools. So you think of, in a neonate, you think of a necrotizing enterocolitis. Necrotizing enterocolitis. So the next one now is vomiting. So vomiting that follow shortly after eating is suggested by esophageal or gastric outlet obstruction. So directly after eating, you can have esophageal, gastric outlet obstruction, or you have a peptic ulcer disease. So however, it may be due to a psychogenic, so like in cases of anorexia nervosa, or in the case of a bulimia. Are you getting? So vomiting that occur after ingestion of specific food may suggest a food allergy. So we have persistent progressive projectile non-bilous vomiting that occur immediately after feeding in infants between 2 and 12 weeks of age is suggested by pyloric stenosis. So between 2 to 12 weeks of age, persistent non-bilous vomiting in infant that's usually feeling well and eager to eat is pyloric stenosis. Effortless vomiting is otherwise newborns may suggest a gastroesophageal reflux disease. Early morning vomiting may suggest pregnancy in adolescent female or increased intracranial pressure, brain tumor, particularly when there is no nausea. I've initially told you, when increased intracranial pressure, you just have vomiting without a particular period of nausea. Chronic vomiting may suggest a partial mechanical obstruction of the gastrointestinal tract, e.g. hiatal hernia, or a chronic gastrointestinal disease. So a chronic vomiting may suggest a mechanical obstruction of gastrointestinal, a partial mechanical obstruction of gastrointestinal tract, that's hiatal hernia, or a chronic gastrointestinal disease with inflammatory bowel disease or celiac disease. Pelvic junction obstruction or common bile duct stones can present as vomiting. So we are finished with that. So the next thing we're going to visualize is acute diarrhea.